I'm Camilla Pavesi, the Wellbeing Specialist in Human Resources. I want to thank you all today for joining our CUHR benefits and the CUIMC practitioners in our our inaugural CU Thrive series. And CU Thrive is a community of lifestyle and learning. And this inaugural session is focused on cardiovascular, heart healthy preventative behaviors. So just to go over a few things here, right? Our heart's a muscle. It pumps oxygen-rich blood throughout our body. So today we're here to learn a little bit more, right? Like, what else do we need to know? What's heart healthy living? Is it understanding our risk? Is it making healthy choices? Is it taking steps to reducing our overall chances for heart disease? And so, what better way to give you all this important information? We have an expert panels of CUIMC doctors here to give you these insights today. So I'd like to introduce you to Sarah Loop, the Executive Director of Benefits and Human Resources. And Sarah will be introducing our panelists today.
Good afternoon. Thank you, Camilla. It's a pleasure to be here. I hope everyone can hear me okay. I will turn my volume up a little bit louder. Excellent. Well, welcome. This is our first CU Thrive event, hosted by Columbia University Office of Human Resources. And we are just thrilled to be here today with some extraordinary panelists to talk about heart health. I'd like to introduce you first to Dr. Yelitza Castanos, who's an adult gerontology nurse practitioner and an assistant professor of nursing at Columbia University School of Nursing, where she completed her master's in science and her doctorate in nurse practice. She has over 10 years of nursing experience in psychiatric nursing, community health, leadership, and primary care. Her clinical interests include disease prevention, health promotion, complex chronic illness management, and family planning. And her research interests focus on palliative care, women's health, endocrinology, and preventative care. Welcome, Dr. Castanos. Thank you for being here with us today. I'd also like to introduce Dr. Corey Bradley, who graduated from Cardiology Fellowship at Columbia and recently joined CUIMC faculty with a clinic in Midtown. Dr. Bradley is passionate about preventative cardiology and is boarded in clinical lipidology. Her practice focuses on primary and secondary prevention and treating complex lipid disorders. And her research focuses on understanding barriers to utilization of lipid-lowering therapy and how to better identify patients who are undertreated or untreated for heart disease. Welcome, Dr. Bradley. It's a pleasure to be with you today. I'd also like to introduce Dr. Margaret McEntegart, who is Director of Cardiac Catheterization Labs, Director of CTO and Complex PCI, and Associate Professor of Medicine at CUIMC. After Cardiology Fellowship in Scotland, Interventional Cardiology Fellowship at CUIMC, and Clinical Research Fellowship at Harvard University, she became a consultant interventional cardiologist at the Golden Jubilee National Hospital, an Associate Professor of Cardiology at the University of Glasgow in 2011. She returned to New York to take up her current position in 2022. Welcome, Dr. McEntegart. It's a pleasure to be with you today. And last but not least, I'd like to introduce Dr. Biana Roykh, who is a clinical administrator focused on excellence in patient care delivery and education. She is an associate professor and serves as Senior Associate Dean for Clinical Affairs at the Columbia University College of Dental Medicine. Biana oversees community-based initiatives, pre-doctoral and postgraduate dental clinics, and a network of Columbia Doctors Dentistry faculty practices. Some of her key professional interests and impacts are in access and improvements to health equity and system science approaches that continue to redefine value-based care. Welcome, Dr. Roykh. It is an absolute pleasure to be with you today. Thank you, everyone. I'm going to turn this session over now to Camilla, who's going to engage with our panelists on a variety of topics around heart health.
Thank you, Sarah. Can you all hear me better now? All right, wonderful. Well, so we're going to start off with the basics, right? We typically tend to see the heart health know your numbers for testing. So we're going to start off with Dr. Bradley, who's going to go or explain to us, if you can explain what the numbers typically mean and what annual labs should we complete with our healthcare team or our PCP.
Yeah, so adults over the age of 40 should, in general, get their cholesterol checked about once a year. If you're younger than 40, it can be less often, but that depends on sort of your baseline values and also your family history of heart disease or stroke. HDL used to be thought of as the sort of quote unquote good cholesterol, but new research is showing us that it's really more likely neutral rather than good. And however, we do know that in contrast to LDL, really low HDL is also probably not a good thing and can be raised with lifestyle interventions. LDL is typically the one to watch out for and represents the disease causing cholesterol that leads to blockages in the heart, brain, and the vessels of our legs. And our LDL goal depends on the health, your sort of overall general health, but also your risk factors for heart disease and stroke. In general, for a healthy person with no family history, an LDL around 100 is considered safe. Lower, however, if you have other risk factors. And unlike HDL, with LDL, there's no such thing as being too low. So as a result of that, you should talk to your provider about sort of your overall risk for heart disease and stroke, and then whether or not lifestyle changes or possibly medications would be sort of recommended to lower your LDL. Triglycerides reflect primarily how our body is processing dietary fats and carbohydrates. And so when these are elevated above 150, you should talk to your provider about why this might be happening and if there's anything you can do to help change your diet, which will help your triglyceride levels. And it should also be noted that on the lipid panel, the triglycerides are actually the only value that's affected by fasting. So if you're just getting your lipids checked to follow up, perhaps like your LDL response to some sort of change in your diet or your lifestyle, typically fasting labs are not required for that.
Thank you so much for that overview. So let's actually jump in. That's for our lipid panel. Let's jump over to what our glucose or our sugar levels should be. So if Dr. Castanos, if you could actually let us know, should we be looking at our fasting glucose for a blood test, or should we really be looking at getting an A1C?
Right. So a lot of times when you get your annual physical, you might have testing for both your fasting glucose level and your A1C. So I'll just talk a little bit about the difference between the two. So hemoglobin A1C generally shows us an average of the last 3 months of what our blood sugars have been. And in terms of know your numbers, ideally for everyone, we want to see a number of 5.7 or less, which means that at that level, we are at very low risk for diabetes. Once we reach the levels of 5.7 to 6.4, at that range is where we're considered pre-diabetic, and it's really where we want to emphasize exercise and diet to kind of prevent going into the diabetes phase. So anything above 6.5 is considered diabetes, and that's with the hemoglobin A1C. When we do a fasting glucose level, that's generally done as part of a panel that usually includes our other electrolytes and our kidney function as part of the test. And generally, we want to see those numbers at less than 100. Some patients may have like 102, 103, but we really want to look at the overall picture. But in terms of knowing your numbers, if you have a range of 100 or 125 and you have been fasting meaning that you haven't had anything to eat for at least 6 to 8 hours or longer, then we want to consider additional testing to identify if there's any risk factors for prediabetes.
Thank you so much. Can you also let us know, or a little bit more insight on how does diabetes overall play on our heart health?
So with diabetes and heart health, they come hand in hand because diabetes affects different organ systems in our body, one of them being our heart. One of the things that it can do is cause microvascular damage and macrovascular damages as well. So it can affect how our heart is pumping, increases your risk for types of MI, strokes, heart failure. So it does have an impact hand in hand. So ideally, to lower these risk factors, if you are diabetic, you want to make sure that your A1C is ideally under 9, where it's really well controlled. And now with newer medications, they do have these like cardioprotective barriers to kind of help protect your heart from having these possible cardiac events in the future.
Thank you so much for that explanation. And just to put out there to all our participants here today, thank you so much for the questions. We're going to hold them until the end of the session. So if you can stick around with us to see where we can come with those, because perhaps some of your questions may be answered throughout the questions coming up. So thank you. And now actually let's And the third know your numbers is actually our blood pressure. If Dr. McEntegart, you can let us know, how does blood pressure play a role in our heart health? And what should our optimal blood pressure be?
Thanks. So the really important factor about blood pressure is really twofold, I suppose. One, in terms of the risk of affecting the heart itself, both in developing coronary artery disease and also in developing left ventricular hypertrophy, and ultimately, if it's really poorly controlled, cardiomyopathy. But then also, really importantly, in your stroke risk. So it's really important that we keep on top of this as the third kind of most modifiable of our risk factors for all vascular disease. So over the decade I've been in practice, there's been a real evolution in our thinking about how aggressive we should be about blood pressure. So back 10 years ago, we were looking at 140/90 as being abnormal. Now that's considered to be really stage 2 hypertension. And now we're looking at normal as being 120/80. So a really big difference from where we were thinking about this 10 years back. And that's to do with what we know from research and from the data in terms of how that affects your vascular risk, both your cerebrovascular and cardiovascular risk. So anything over 129/80, up to 129/80 is considered elevated. So if you're running those levels, you really need to start paying attention to that. And once you get up to over 130/80, you're considered to be stage 1 hypertensive. In terms of what we can do about that, there's lots of lifestyle things we can adjust and change, and I know we're going to discuss that as we go forward in the webinar. But the main thing really is to have it checked at your annuals, and also if you're in that area where you're already elevated or you're stage 1, really to start to keep on top of the monitoring of that and considering initially lifestyle changes and then whether you need medication for your long-term risk reduction going forward.
Thank you. So if everyone heard that, again, to reiterate, it's under 120, under 80. Incredible. Thank you. And so now you're all probably wondering, we have a doctor, a dentist on the panel. So we're trying to also think outside of the box here. What are other tests that should be done for our heart health? And typically many may not associate dental health with our heart health, but dental health is certainly beneficial for our heart. So if Dr. Roykh, if you can let us know, what's the connection between our dental hygiene and our heart health?
Thank you so much, Camilla. It's great to be here with everyone today on this panel. Well, most people think about getting their cleaning done for their teeth is just about shiny white teeth and making that bright smile, and it just feels so glamorous. But actually cleaning, it has a lot to do with disrupting our bioflora. So there's a sticky substance that bacteria lay down on the gum line where the tooth and the gum meet. And that stickiness makes it easier for more bacteria to attach to the tooth surface. And so that bacteria can sit there and really wreak havoc on our gum condition and lead to gum disease, also known as periodontal disease, right? This is a chronic kind of inflammatory condition that sends different factors throughout our body and keeps our body at constant state of this inflammation that we're trying to constantly fight and subdue. So you really getting cleanings done, it has a lot to do with disrupting this microbial environment. And once you disrupt it by having a professional dental cleaning, it makes it more challenging for bacteria to stick, and it takes longer for those bacteria to rebuild their village and their fortresses and to start to attack your oral health. So, it's a known fact that people with gum disease have about 2 or 3 times higher risk for having heart attacks, stroke, and other serious cardiovascular events. Even though there's no science to prove causation, right? There's no science that says if you have a periodontal disease, you will have cardiac problems. You certainly have patients with healthy gums who have cardiac problems and vice versa. But it is, there's definitely a correlation, and there's a growing suspicion that gum disease may be an independent risk factor for heart disease. And so, it's clear that connection is really clearly understood, that gum disease increases that burden on the body to fight off that chronic inflammation. And the connection is so compelling that, this is why doctors and dentists recommend that we are very vigilant about keeping gum disease under control and being very preventive. So it's very, very important for everybody to go see their dentist at least once a year for checkups. And even for healthy gums, for prevention, we recommend 2 cleanings a year. That helps to keep things at bay. If somebody is struggling with chronic periodontal disease or gum disease, then the dentist might recommend cleanings 3 or 4 times a year to help keep ahead of that chronic inflammation process.
And I have a follow-up to that. So can you just let us all know, what's the prevalence of actually gum disease is it silent within our population?
It's actually one of the most prevalent chronic conditions in the United States and potentially in the world. The statistics show something like 1 out of 2 patients has some measure of chronic gum condition. It can range from gingivitis all the way from mild, moderate to more advanced periodontal disease. So it's very, very prevalent, and it can lay very silent and very dormant, right? A lot of times you don't notice, you don't know that you have gum disease until your teeth become very wiggly. And that wiggliness means that you've lost a lot of bone. And that kind of process takes many years, sometimes decades to take hold. Some people can have a more aggressive version, but in most of the population, it's a kind of a slow deterioration. So we really know that it's silent. And the way to get ahead of it is to have good hygiene at home and to make sure that you see a dental care professional regularly.
Oh, wonderful. Thank you. So you all heard that. Go visit your dentist. And so besides getting our teeth regularly cleaned and our annual blood work, this is going to go out to all of our panelists. Are there other tests or screenings that you would all recommend either we be aware of as patients or to ask our healthcare team for? Just perhaps actually we'll start with Dr. Roykh if there's one that you would recommend that you're aware of.
There's a lot of work in science in the genome, try to understand the sort of the biomechanics of how we can lean on therapeutics to detect and reduce our risk for chronic conditions such as the gum disease. There are no specific tests currently available. It's really detected more through radiographic imaging. So digital x-rays is something that dentists do and hygienists do to help diagnose. There's a lot of advanced AI technologies out there. Some of you may have heard of a company called Overjet that actually takes a photograph of a scan and can trace the bone levels and begin to make projections about the level of disease and bone loss, and even project out over years and time, if left untreated, how the condition might be in 10, 15, 20 years. So there are AI technologies that I think will become more readily available for home use for patients in the next decade, where patients will be able to self-diagnose some of these conditions. But currently, the mechanical evaluation that the dentist or the hygienist done with a probe to measure the depth of pocket and the x-rays is the best way for us to currently diagnose the condition. And then we see the patient with a recurrent pattern to observe any small changes in that pocket depth. That tells us how active the disease may be at any given time.
Thank you. Dr. Bradley, do you have any other suggestions for additional tests that we should be aware of or screenings?
Sure. One of the things I talk to a lot of my patients with is calcium scores. I think it's something that a lot of people now have questions about and are starting to hear more about. And so something I hear a lot is, do I need one and what's the role with this? So I typically explain to people that calcium scores help us understand your risk. A calcium score is a sort of low radiation, no contrast CT scan. It's very quick and gives us an estimate of how much calcified plaque is in your heart. This directly correlates with the risk of future cardiac events. And so based off of your number, in an asymptomatic person, it can help us understand the risk for heart disease and also decide a good LDL goal for you and when, or have a more focused conversation about when medications for your cholesterol might be necessary. If your calcium score is 0, that's great. It means there's no calcified plaque present. It doesn't necessarily mean that there's no soft uncalcified plaque, but the calcium score itself does not measure that. So I generally tell patients that if you are high risk or you have high concern, we can consider repeating 1 in 5 years. If your score is not 0, then generally we don't repeat it, because at that point we know that there's some evidence that heart disease is already present, regardless how severe. And then other tests down the road will be more helpful in sort of really classifying your risk and the severity of your heart disease. People also have concern about the cost of calcium scores because they're not covered by insurance. I can't speak to where they are everywhere. The cost does vary, but I know at Columbia, we can do a calcium score for $150 cash. You can get them cheaper at other sort of outside centers as well. And often your physician can help you sort of discuss whether or not this cost would actually be worth the cost for you, or if it's something that maybe to consider down the road or not at all, depending on your situation.
Thank you. That's very valuable. And can either Dr. McIntyre or Dr. Castanos let us know, does everyone need a heart stress test? Because oftentimes people ask, right, also, what's a stress test?
So this is it's an interesting topic of conversation, Camilla, and having moved from one healthcare system to another healthcare system, it's been something which I suppose I've been in transition. So in the UK guidelines state that you only stress test patients that have symptoms. We don't use stress testing as screening. And in fact, the UK guidelines now suggest that when patients come with suspicion of coronary disease, that actually the first line test is actually a coronary CT scan as opposed to a stress test. So it's kind of interesting to transition to a different system. But as Corey said, there's a higher use of calcium score here just to get an overall kind of cardiovascular risk for a patient. And then also still a high use of stress testing in patients to both screen for coronary disease, but also, as Corey said, to try and risk stratify patients in terms of whether they need further investigation or further more invasive and aggressive assessment to see whether they have got coronary disease. So it's very interesting. The way I approach this, I'd be interested to hear how the others approach this in the office, but the way I approach this in the office is that I tend to have a very kind of one-to-one personal conversation with the patient, because everybody's perception of risk and how that impacts on how they feel about their life and their future is quite different. And you have some patients who actually want less, and they want really just for you to screen them and test them if they feel there's something wrong. And you have some people who really want to be on top of things and really be able to future-proof what their future vascular and cardiovascular risk is, and they'll want much more aggressive assessment. So I tend to take I suppose someone very specialized in coronary disease, I tend to take a very patient-centric approach to the situation. And I think it's a kind of dynamic area, especially as our ability and the quality of the tests we do now are improving, especially with the advancement in CT scanning to help us more non-invasively assess your cardiac status. I'd be interested to hear what Corey's take on that is.
Yeah, I think you raised a few really good points. One being that I do typically describe to people that I think the role of stress tests is when symptoms are present. I think that non-invasive approaches such as either a calcium score, if you're truly asymptomatic, or a CT scan, if my pretest probability is quite low or lower, generally is my preference, just because especially in young people, you get a lot more anatomic information that might be a cause of symptoms rather than just typical coronary disease like we think about in older populations. That being said, I think something too that I didn't truly understand until I became a cardiologist was that the value of a stress test is actually pretty dynamic depending on your assessment as their provider of their risk going into the test. And so not if you're a very low risk person, the test is actually far less predictive than if you're a high risk person, which can be a difficult thing sort of to statistically to wrap your mind around. But I try and tell people that a normal test in a truly low risk person, is actually not necessarily that reassuring. And then I think that also the idea of having a true conversation with people about about what they want to know. I mean, I'm on the other end of the spectrum. I see a lot of people for primary prevention. And when I'm talking to them about these tests we can do, I just say, how much data do you like? Are you someone who likes a lot of information? Do you want a lot of data points? Do you want the numbers to all these tests so that you have that information either as a peace of mind or to be as aggressive as possible right now? Or are you someone that just kind of wants the basics and to see how things evolve over time? And knowing where someone's head is at can help your provider really tailor sort of what types of testing and investigation and how far down sort of a road to go.
Thank you. So actually, let's jump into our next portion here, which is actually looking at genetics, right? Like, how does genetics play a role in our overall health? But what does the impact of genetics play on our heart? So if Dr. Bradley, you want to kick us off on what does that mean for us?
Yeah, so genetics play a huge role in determining our risk for heart disease, and I think we're learning more about this rapidly right now. One of the major risk factors for having a heart attack or stroke is if you have a family history of these types of events. And so with cholesterol, for example, what most people don't understand, I apologize, the sirens in the background, but what most people don't understand is that about 80% of your cholesterol value for a typical person is determined by genes rather than by diet or lifestyle. And so that means that even in the healthiest person who exercises and eats right, there's only so much that lifestyle changes can do to control our risk of having elevated cholesterol. And so that's really where the role of medications is, because there's only so much we can do, again, in a typical person with lifestyle interventions. But for some people have multiple affected family members. We usually consider that with first degree relatives. So think parents, siblings, children. And in families that have a really high rate of events, and you can track cardiac events, up through multiple generations, sometimes that's when we think about genetic testing to investigate if there's something else going on that could be causing a risk we haven't identified. And I would just emphasize that, as we're learning more and more about this, if you know that heart disease or even high blood pressure, high cholesterol run in your family, you should really try and seek out screening or speaking to a specialist or primary care doctor earlier rather than later, because it may mean that for you, testing should be, more often than our general guidelines would suggest.
Thank you so much. And actually now, even thinking about age, does our age play a factor in our heart health? And what should specific age ranges be working on? If Dr. McEntegart, if you can explain that a little bit for us.
Yeah, so we know that the prevalence of all cardiovascular disease essentially increases with age. And if we circle back to Corey's discussion earlier about the calcium scores, there's a lot of data now that shows a really straight line correlation between how old we are and how much calcium we have in our coronary and our vascular tree. So every decade we age, the higher our risk of all these cardiac and cerebrovascular and vascular diseases becomes. And there's all we can have arbitrary cutoffs at over 40, over 50, over 60. But the reality of it is it's a continuum that we follow. Now that continuum is different for men than it is for women, because we are to some degree protected premenopausally, and there's a kind of delay in the instance, particularly of coronary disease in female patients to the postmenopausal stage. And that obviously is also shifting as we see an increased use in HRT in women in their 40s, 50s, and 60s. So it's going to be interesting to see how that evolves over time as we move forward. And we see the impact of that. So yeah, so age is essentially completely consistent with the evolution of our vascular disease. And you can see a patient who's 50 who has the physiology and the presence of a 30-year-old, and you can see a patient who's 50 who has a physiology in the presence of a 75-year-old. So it's as we always say, age is a number, and it's really how you manage your age and how you manage your physiological age that really matters. And it is possible to delay the aging of your cardiovascular system and your vascular system in the same way it is possible to delay aging of your whole body by adjusting your lifestyle and addressing all the risk factors that we're discussing this afternoon.
Well, wonderful. Thank you so much. That's actually a perfect segue into our preventative measures. Let's now think about all of our modifiable actions that we can take, like take charge into our own hands. So the factors that we typically see with heart health are either diet and exercise. So of course, we're going to start off with that, but how important and impactful, I should say, are these lifestyle choices that we make from day to day? So if we can start off with Dr. Castanos, if you can kind of guide us a little bit more into what are the lifestyle interventions to prevent heart disease in terms of our nutrition should we really be focusing on?
Yeah, so there's a lot of different diets out there. What do you follow? What's appropriate for the heart? So in research, they have found that a lot of these diets that they looked at, plant-based diet, the Mediterranean diet, heart healthy diet, the main focus in all of these diets were high in fruits and vegetables, high in legumes, high in whole grains, seafood, if that's something that you enjoy eating, alcohol in moderation. And generally is reduced amounts of processed foods, red meats, refined grains, items with high added sugars in it, trans fats, saturated fats, and sodium. And ideally, this brings us back to reading the nutrition label, right? Looking at our labels and making sure, okay, does this item have trans fat? And what does this 5% mean? What does this actually say for my nutrition? What does this mean for calorie intake? So a lot of these nutrition labels are based out of a 2,000 calorie per day consumption. So when you're looking at saturated fats, you want to look and make sure that it has less than 5%. Anything higher than 20% is really considered really, really high. So those are the kind of foods that you want to avoid with saturated fats and trans fat. Ideally, none of your food should have trans fat, but unfortunately, sometimes, we have to just make sure that we're educated and we know how to read these food labels. So all of these have shown that lowers your risk for heart disease, diabetes, and strokes, generally in 30% or more, as nutrition is something that we can control for the most part. And, sometimes people have different other social determinants of health issues that may impact the nutrition. But ideally, this is the overall kind of philosophy that we should follow in terms of keeping ourselves healthy.
Thank you. So yeah, everyone, we all need to learn how to read a food label, right? It's not as intuitive as we may think, but thank you so much. And now, Dr. Bradley, if you can guide us a little bit more on the lifestyle interventions in terms of movement and fitness that we should know.
Yeah, so, I recommend that patients sort of first have an honest conversation with themselves about like what they can do today, rather than perhaps a future, unattainable goal like running a marathon. It's always important to start with something that is that is meeting you at your level right now, because it's also going to help you stay motivated if you're succeeding at your goals. So the guideline that we have is that people should try and exercise about 150 minutes a week. And for all of us, that might look very different. So it does not need to be all cardio exercise. I recommend people first figure out what they enjoy, because with everyone, your time in your day is precious and exercise should not be miserable. And so it can be a mix of doing things to get our heart rate up, but also focusing time on building muscle. And you don't need a home gym to be able to start. There are free exercises available on things like YouTube, where you can find videos that for strength training that use minimal or even no equipment to help build strength. And then for the movement activities, to really raise your heart rate, that can, depending on where you're starting from, that can be anything from brisk walking to jogging, tennis, pickleball, sort of whatever it is that gets you moving and gets your resting heart rate up.
Thank you. Yeah, so if we can all space out our movement throughout the day for that 150 minutes. So 20 minutes roughly. So thank you for sharing that with us. So another huge component, right, of our lifestyle interventions is that we should be really focusing on is sleep. So if Dr. McEntegart, if you can let us know, how does sleep affect our heart health and what should we be aiming for?
Yeah, so this is a topic I'm really interested in actually, and I've kind of been reading around it and listening to lots of podcasts about it. So there's now actually a frightening amount of data that shows that sleep is a very strong predictor of our mortality and our cardiovascular disease, but also all the major diseases, our cancer risk, our stroke risk, our aging, everything. And it's something that I hadn't really paid so much attention to when I was a young physician, because obviously we kind of pride ourselves on being able to work really hard and long hours and surviving as little sleep as we absolutely needed to have. But as I get older, I'm starting to realize that it's really been a false economy. So there's a lot of data to show that we should really be striving to get 8 hours sleep a night, which is something really that for a long time I never ever was able to achieve. But now that I'm working really hard to try and manage that. And it's really compelling. So I'd encourage you to read around this. There's some really interesting, popular books you'll see on the kind of bestseller non-fictional bookshelves around about this topic, and that are very engaging, and you'll really learn a lot about it. So I've really started to work hard on going to bed a lot earlier than I was before because of all the early starts, especially here in the US, having moved from a UK timeline to a US timeline. The day starts at least an hour earlier. So really trying to get to bed early, and trying to rest properly. Now, one of the things that's incredibly important is the whole no TV, no laptop, no phone in your bed. There's now a huge amount of data that blue screen light from your phone, from your laptop, from the big plasma TV is really disruptive to your sleep and the quality of your sleep. So they say now that for the hour before you actually want to sleep, you should try to remove all that from your space. And we should all be going back to old-fashioned books in bed, and or audiobooks if you don't want to. So I'm a big audiobook person actually. So I've tried to switch to using audiobooks to get to our podcast to get to sleep at night. And tried to remove, they now talk about phone hygiene. You should not have your phone beside you in bed. It's very, very bad. And the other thing that's really awful that I have been guilty of is you wake in the middle of the night. Yeah, I'm getting older and I wake up in the middle of the night. You check your email, you're then thinking about the next day at work or what happened at work. It's a complete disaster for your rest. So try and not use your phone as an alarm. Try not to look at your email in the middle of the night or your social media or whatever it is that's going to get your brain turning, and try and go back to good old-fashioned books or audiobooks when you're going to bed, and instead of watching Netflix on your laptop.
Thank you. Oh yeah, the phone hygiene. Absolutely. We all need to reassess what that looks like for each and every one of us. And so to our, I guess even the next point is, let's think about our stress, right? What lifestyle interventions to prevent stress, to prevent heart disease? If Dr. Roykh, if you have some insights for us on what that looks like for our stress in terms of our heart health, what can we do?
It's complicated. I mean, we know that, of course, we're a complex organism. And so everything that we do sums up together to affect our overall well-being. Certainly, when we think about stress, we also think about mental health and the overall general function and well-being. And we can't think about risk of a heart disease without thinking about mental health and well-being. I think that it's important for people to figure out, ask themselves, how do they unwind? How do they find relief from the day? And we just heard from Dr. McEntegart a little bit about, sleep hygiene and phone hygiene and what we need to be doing to help us unwind. But certainly figuring out what makes us tick, to give us a moment. Maybe it's a walk in nature. Maybe it's breathing exercises. There are so many cool ways to unwind nowadays, even in a very complex world that we live in. And making a conscious effort to, like Dr. Bradley said, to figure out, what can I do this week? What am I going to do this week to help myself get through the week, particularly if you're planning for something really complex. But for patients who maybe are struggling with depression, we know that that could be very challenging, right? Because depression can also be silent in many ways. It's not always presenting the same way in all of us. But certainly if you're feeling yourself lacking motivation, having a hard time sleeping, decreased interest in social outlets, the things that make us kind of unwind and be in that network, that's something to pay attention to and reach out to your healthcare provider, your primary care doc. Maybe start there to think about what opportunities and options exist. Definitely paying attention to mindfulness and well-being.
Thank you. Yes, so important, right? That we may overlook how our mental health obviously affects our heart health, which even onto another point and has to how pollution or smoking and vaping or even alcohol consumption can actually also deal with our heart health. If Dr. Bradley, if you have any insights for us on any or all of those.
Yeah. So I'll say just, first with alcohol, alcohol use is one of the major causes of high blood pressure. And so we typically think of smoking or caffeine as things that raise our blood pressure, but actually alcohol is a very big predictor of developing high blood pressure. So that is one thing. If you're recently diagnosed or told your blood pressure is sort of starting to become elevated, one thing to think about. And then alcohol also raises your triglycerides and is one of the most common causes in our diet that people end up with elevated triglycerides. In terms of smoking and vaping, I mean, both put an enormous amount of stress on our body. Unfortunately, they're also some of the hardest habits to quit. So I emphasize also that, I recommend reaching out to your healthcare provider about what tools are available, because this type of habit, because it's reinforced multiple times a day, whereas many other addictive behaviors are not, it can just be really difficult to do by yourself. And there's absolutely no shame in seeking for, now that we have so many tools in the toolbox to help quit from nicotine use. Unfortunately, we see a sharp decline in your risk of heart attack and stroke even by 1 year after someone quits smoking. And so these benefits exist whether or not you've been smoking for a long time or a short amount of time, and your body starts to see the benefits really quickly. And because vaping is relatively newer, we don't have as much long-term data about vaping and heart disease as we do with just tobacco cigarettes. But we do know that nicotine by itself raises your heart rate, causes your blood vessels to constrict, which limits the amount of blood flow and oxygen delivery to our tissues, and does raise your blood pressure. So it's certainly not a harmless alternative. And I frequently will sort of discuss with my patients exactly where we're starting in terms of their smoking and vaping use, and then try to develop a plan to cut down over time. And whether that includes also nicotine replacement therapy or not, it's just such an important risk factor that we really can't forget about it. And it makes a profound difference in your risk the moment you stop.
Thank you so much for sharing that. And actually, you brought about a beautiful point about how do we start with these heart healthy behaviors, right? So Dr. Roykh, if you have some insights for us on why or how patients can start these habit forming behaviors.
Yeah, one of the toughest things is, behavioral change and making new habits. And we've been discussing this with panelists, right? How hard it is to make a new habit. When I work with patients in dentistry, one of the things that we know is important to good oral health is flossing, right? And then when the patients always do this, they'll floss right before the dental appointment to try to look good and, try to trick us. But really, what we want to make sure is that we stay on top of our oral hygiene every day, right? And so it's important to build that habit. And the way I advise my patients to start building that habit is know yourself, know where you spend your time. A lot of times people feel like, well, it's the end of the day and I'm brushing my teeth and I have to stand there and lean over my sink, and it's just annoying to then deal with that floss. It's just too much. So I tell them, if you spend time at the couch, you're watching Netflix, you're relaxing with your loved ones in the family room, have floss laying around in different areas. It's relatively inexpensive, and it's okay to have 5, 10 flosses laying around in every room that you might find yourself spending time in, kitchen, whatever. And just if it's already within your reach and it's easy, you've already reduced that barrier to, it's not an event that you have to plan and prepare for. You can just casually start flossing and adopting it into whatever routine you're doing. And that could be part of your 5 minutes to yourself, that mindfulness, that relaxation almost. You're taking care of yourself. So figuring out where you spend your time, what habit you're trying to adopt, and how you might make it fit into your life, I think is a very important first step to adopting a new habit.
Thank you. Very important for us. And in the sake of time, I'm going to actually ask our final question. So this is to all the panelists. So I would like you all to have a response, which is, what's the final takeaway you would like us all to walk away with today that's concerning our heart health? So if Dr. Castanos, if you want to start us off today.
Sure. I think one of the biggest takeaways is, make your annual physical appointments, come in and see your primary care provider, go in and see your dentist, give it as a gift to yourself that you're healthy and you want to stay healthy for many years to come. So I think that's one of my biggest takeaways is go and see your primary care providers, be mindful of what you're eating because all that impacts you, and be kind to yourself and exercise as much as you can.
Dr. Bradley?
I think mine is pretty general, but just in general, don't be intimidated by the concept of lifestyle changes. I think it's one of the quote unquote easiest things in medicine to do, but it's in fact the hardest. It's a lot easier to change your diet. I mean, a lot harder to change your diet than to take a medication. And so I like to tell people, be honest about where you're starting from and pick just 3 things that you can do that you could do for the rest of your life. We're not going to change, go from one day eating fast food regularly and never cooking to being a vegan the next day. It's just not a realistic thing to expect yourself to be able to do. So start small, make really achievable goals and build from there. But think about changes that you're trying to implement in your life as something you're implementing for the rest of your life, not just for the next 2 weeks. And it'll be way easier to stick to these goals and to these new habits.
Thank you. Dr. McEntegart?
Yeah, one other tip that I would add that I think works is we're creatures of habit. That's why it's difficult to break these behaviors. So one thing that I've found works for me over the years, if you identify something you feel is an adverse habit, be it that you're smoking or maybe you're drinking a little bit too much or you're not sleeping properly or you're developing bad habits, staying up late at night, is replace a bad habit with a good habit. Right, so become habitual about something good in replacement for something bad. That really works for me. So commit to something. So sign up for a yoga class or something that's going to change your evening routine, change your habits. So think about things you want to change. As Corey says, 2 or 3 things you think are really important to change, and think about what could I replace them with, which will distract me from that habit and become habitual if it's something that's positive.
Great advice. Thank you. And of course, last but certainly not least, Dr. Roykh.
Back to me.
Yes.
I think it's nice to do it with a friend or family member or buddy. So if there's something that is easily shareable as a new habit that you want to do, and it's you can engage the whole family in it. That's certainly something that I think could be great. Whether it be a diet change, particularly things that are big lifestyle changes like your nutrition and your diet, right? It's hard to cook something very separate for yourself than you would do for your loved ones or your family. So kind of making it a fun family event. If you have an opportunity to engage a buddy in a new habit or a new thing you want to be obsessed about, that's a healthy thing instead of the bad habit. I think that's definitely very important. And I just would say the second thing is not to give up. Just because you had a goal and maybe you didn't reach it, or there were some circumstances, there's learnings that you can take away from what worked and what didn't. And you can go back and tweak and retweak until you hopefully start to see some measures of success. And so not to give up just the first time that you've tried to build a habit or take on a new change.
Thank you all. Oh, that was incredible insights today. So Sarah, if you want to hand them over some fabulous questions from our audience. So again, please make sure if you can all type it into the chat box, questions that you would like our fabulous doctors to respond to today.
Thanks, Camilla. Yeah, we have some good questions already teed up. So I'm going to see if Dr. Bradley might be able to answer this one. So someone asked a question about the side effects of medication for cholesterol. So could you speak a little bit about that?
This is one of my favorite topics and something I spend a lot of time talking about in clinic. So generally when people are thinking about medications for cholesterol, we all think about statins. It's the most common medication that we use for cholesterol, and it has probably the most evidence of all medications we use in cardiology to decrease your risk of heart disease and stroke. But people get concerned because there's a lot in the media about risks of side effects with statin therapy. The primary thing that people talk about is muscle cramps and muscle aches. And statistically, myalgias or muscle pain is the most common side effect that's reported and found in large clinical trials. And when we talk about this, it's usually, again, not always, but usually pain that people have in their biggest muscles. So think, your most proximal muscles, your deltoids, your quads, your hamstrings, and it's an aching that typically people feel a couple hours after they take the medication. It actually happens in fewer than 5% of patients who take statins. But anecdotally, people report it to be much higher. And the thing that I like to emphasize to people is that statins have what we call the nocebo effect, meaning that we found that when we do really large trials, that's like 20,000 patients, people who think they're taking a statin, but are in fact not, actually have the same incidence of side effects. And so whereas we think of placebo as you get a benefit when you're taking a sugar pill, the nocebo effect is that you have a side effect even when you're taking a sugar pill. And so it's really the association of thinking you're taking a statin that's associated with these the high incidence of side effects. And when we take people in clinical trials and we switch them back and forth between placebo and statins, most patients can't tell the difference. And we've also found that if you had side effects to a statin, but we were able to retrial it, generally people will tolerate it. And I also want to emphasize that there are 7 different types of statins. They're metabolized differently in our bodies. So just because you have a side effect or again, this muscle aching to one of them doesn't mean you'll have it to a different one. And so we have a lot of room to try different types of the medications, play around with different dosing. And sometimes that means getting people on just a really low dose that they can take 3 times a week. So it's about meeting you where you are. There are some other side effects. We generally think about potentially statins causing liver injury. And then the most significant thing would be actual real damage to your muscles that can cause kidney dysfunction, which is exceedingly rare. That being said, it's obviously good anytime you start a new medication to make sure you're in communication regularly with your doctor if something doesn't feel right. And I tell people, just because we start it doesn't mean that we're wed to this medication. We can stop it if it doesn't work for you, and we have a lot of other options to explore. Right now is a really exciting time to treat high cholesterol because we have a lot of new drugs coming out, and many of them are tolerated exceedingly well. We have injections that you can take every 2 weeks or once a month, and now we have a new agent which actually is injected by a doctor or a nurse practitioner or a nurse once every 6 months. So there's really good options out there if statins don't work for you for whatever reason. And I've never had a patient that I couldn't find a cholesterol lowering medication as long as we just communicate a lot and work together to find something that works for the patient.
That's wonderful. Thank you, Dr. Bradley. That's so insightful. Maybe Dr. McEntegart, you might be able to answer this question. Someone has a question about heart murmurs. Are there ways to cure heart murmurs, or what should be their next steps if they're diagnosed with a heart murmur?
Okay, so a heart murmur basically is that when we listen to the heart, we hear usually turbulent or high-speed blood flow in the heart, and that can be caused by a whole number of things. The commonest thing we think about is that you've got an issue with one of your valves. Either one of the valves in the heart is tight, it's stenosis, or it's leaking, it's regurgitant, but it's not always that. Sometimes it is just flow dynamics inside the heart. So the first thing is, if you're told you've got a murmur or you've heard a murmur on yourself, is to get an echo. So get a transthoracic echocardiogram. So that's an ultrasound of your heart. It's going to look at all the valves. It's going to look to see if there's any holes inside the heart, or if there's any increased blood flow, speed of blood flow, and identify any other reason that the murmur might be there. Occasionally, you do actually find patients just have what we call physiological murmurs, where you actually echo the heart and it's completely normal, and it's just a flow dynamic that you're hearing. So yeah, first thing is, if you find you've got a murmur, is get an echo and get to the bottom of what the underlying etiology of that is, because it could be a number of things.
Thank you. That's so helpful. I'm going to ask this next question to Dr. Castanos. This is a broad question, but I think it's a great question. Someone's asking, if we make lifestyle changes, is it possible to get off high blood pressure medication? Is there real movement there? Could there be real movement there?
Yeah, I think we also need to consider all the lifestyle and genetics, right? Our family history, what are your numbers per se? Personally, I have seen patients make lifestyle modifications, like really take care of their diet, increase exercise, weight loss, and they have been able to come off their blood pressure medications because they've incorporated all of these lifestyle modifications, but it doesn't work for everyone because sometimes like we had spoken earlier in the panel, our genes, our genetics do play a role as part of how we control our blood pressure. So yes, it's a possibility, but it's also something that you need to discuss with your doctor or provider to figure out if that's something that's a possibility for you in order to reduce heart disease or strokes in the futures.
Thank you. And while we still have you, can you speak a little bit perhaps about a ketogenic diet? Like we have someone in the population who's asking about if it's safe to lose weight using that diet from a cardiac standpoint. Would you recommend that type of diet?
I generally don't. And the reason being is because there has been a lot of what they called rebound effects from a keto diet. Sometimes keto diet is not really a sustainable diet for a lot of people, and they tend to go back and eat carbs again. And I have seen what's called a flare-up where they have rashes all over their bodies that just show up after they stop the keto diet. So personally, I really do not recommend it because there's so many other effects that can cause inflammation in your body from a ketogenic diet also. So not the best.
Thank you. And perhaps one of our cardiologists can just answer this question. What would you advise a patient who has a high blood calcium level? Like if it's slightly above the range, what action, if anything, should they take?
I think one of the things that sometimes also gets misunderstood is that, unfortunately, our blood calcium level actually does not have anything to do with calcium that gets deposited in our arteries. That comes from cholesterol, which is then oxidized and turned into plaque, not the same as dietary cholesterol, which we take in. And so then, but it's a great question because this comes up a lot. So it's not necessarily related to your risk of developing plaques or heart disease. However, a high calcium can be a sign of, a lot of other sort of medical illnesses. So I would recommend, if that is something that's been seen, over time on more than one blood test, to talk about it with your primary care doctor, because some other testing for certain hormonal conditions and other endocrine things might be worth screening for.
Thank you, Dr. Bradley. And I know we only have a few more moments. I think we're only going to be able to toss over one more question to the panel, but I think it's a great question. Any thoughts from the panel on functional medicine for women's heart health? Anyone on the panel? It's a great question. Functional medicine. The panel's gone silent.
So I'll just say, functional medicine was actually something that I thought about a lot in medical school. And most people sort of think about functional medicine as trying to track back to the cause of a problem rather than treating the symptoms of it. It's an emerging area of medicine that has attracted a lot of people who are really committed to sort of a lifestyle approach to taking care of themselves. And so I would say that, I think at its essence, the role of functional medicine in women's heart health is to make sure that you're up to date with your, sort of regular healthcare screening, to talk to your doctor or your nurse practitioner, whomever, if something doesn't feel right, if you're noticing a change in your hair, nails, skin, in your exercise tolerance, to communicate all of these things and really be aware of the symptoms in your body, convey that to your healthcare provider, because sometimes, sometimes they can be a sort of a representation of a larger process that's going on, or a larger change, which might be related to the hormones, sort of as a woman naturally is aging, and we have a lot of other changes that are going on in our bodies. So I do think, especially with cholesterol, our cholesterol is very tied into hormones. It changes dramatically during pregnancy, breastfeeding, and then postmenopausal. So I think there's a lot of potential there, and sort of us better understanding the bigger picture of what causes heart disease. And we're just beginning to, I think, begin to understand how complex some of these issues are.
Thank you, Dr. Bradley. Any final words from the panel before we close? We're getting a lot of nice comments in the chat. There are some questions, unfortunately, we did not have time to get to, but don't fear, because CUHR will have a record of these questions and everyone's attendance, and we'll be able to circle back to anybody whose questions we were not able to get to. Also, I want to thank so much all of our panelists and Camilla Pavesi, Bridget King, everyone who helped make this possible for us. And please keep your eye out for our next CU Thrive. We're not sure when that will be or what topic. It might be on diabetes, it might be behavioral health, but we're gonna reach out for more feedback on what everyone might find helpful. So we're really excited. Thank you all for your participation. And we'll see you again soon. Thank you so much.
Yeah. Bye-bye.
Everyone.
Bye-bye.
Bye.